Greetings, everyone. My name is Ashley Wilson, and this is my presentation on bacterial meningitis for mammalian neurobiology. Today, we will review the neurobiology, genetic considerations, diagnostic criteria, and imaging, as well as the treatment protocol for bacterial meningitis, and a list of references for your reading. Firstly, let's define bacterial meningitis and what that really means. It's helpful to first define what the meninges are. The meninges are a protective layer of tissue that lies deep to the skull and superficial to the neural tissue. There are 3 layers of the meninges. Starting superficially, the 3 layers are the dura mater, the arachnoid mater, and the pia mater, as indicated in the figure. Meningitis is inflammation of the meninges, so bacterial meningitis is inflammation of the meninges as a result of a bacterial infection crossing the blood-brain barrier. The blood-brain barrier is a lining of specialized endothelial cells with tight junctions that line the inside of neural vasculature that protects the neural tissues and interstitial fluid from toxic substances in the blood. The blood-brain barrier plays a major role in controlling homeostasis in the body. There are multiple bacteria that can cause bacterial meningitis. The most common bacteria are group B Streptococcus, Escherichia coli, Neisseria meningitidis, and Streptococcus pneumoniae. This presentation will outline the specific neurophysiology of Streptococcus pneumoniae. S. pneumoniae utilizes multiple pathways to cause infection, depending on the specific environmental conditions that the bacteria encounters once it spreads into new tissues. The specific pathway that this presentation will describe is the pathway utilizing hydrogen peroxide and pneumolysin. S. pneumoniae is a gram-positive, partially hemolytic bacteria that's commonly found in the upper respiratory tract. It doesn't always cause infection. It's opportunistic, meaning it often takes advantage of short-term weakness in the immune system. A healthy immune system can hold off bacteria enough to prevent infection, but a weakened immune system may not be able to maintain that healthy balance. Transmission is often by respiratory droplets, but can also be transmitted from any type of exchange of respiratory secretions, including kissing, sharing drinking glasses, lip products, and toothbrushes. This is particularly important for pediatric patients from ages 0 to 4 months. Kissing infants on the mouth or cleaning pacifiers or the nipple of a milk bottle with your own mouth can transmit the bacteria, and without a fully functioning immune system, infants are more susceptible to infection. S. pneumoniae utilizes 2 key secretions to infiltrate the blood-brain barrier: pneumolysin and hydrogen peroxide. Pneumolysin is a cytotoxin that binds to the cholesterol in the cell membrane, where it attracts more pneumolysin molecules and ultimately forms a small pore in the membrane, allowing entry of the bacteria. Pneumolysin also increases the Krebs-binding protein, which releases tumor necrosis factor, resulting in apoptosis of endothelial cells that make up the blood-brain barrier. S. pneumoniae also utilizes hydrogen peroxide. Hydrogen peroxide disrupts the actin cytoskeleton of the tight junctions, which hold the cells together. This promotes oxidative stress and also results in apoptosis of the endothelial cells. These cytotoxins work together to poke holes in the blood-brain barrier, giving access to the bacteria. In the top figure, actin has been fluoresced. As hydrogen peroxide concentration increases, you can see the actin filaments disintegrating. In the bottom picture, annexin V within the cell has been fluoresced and is visible once the cell dies. As hydrogen peroxide concentration increases, cell death increases as well. After the small pores have been made, fragments from the peptidoglycan layer of S. pneumoniae, as well as teichoic acid, activates a complement pathway, which converts complement protein 5 into C5a, which mediates a potent inflammatory response at the site of infection, leading to inflammation in the brain and meninges. Infection and inflammation in the central nervous system is a deadly combination. 10% of patients diagnosed with bacterial meningitis die, and 85% of the patients who die within 24 hours of diagnosis. Genetic conditions are conditions that occur when an altered gene is passed from parent to offspring, either directly resulting in a medical condition or increasing the risk of developing that specific medical condition. By that definition, bacterial meningitis is not a genetic condition. However, any genetic condition that alters the immune function increases the risk of contracting bacterial meningitis. The manifestations of bacterial meningitis are a direct result of the pressure building in the central nervous system and the spreading infection. Symptoms from the building pressure include headache, sensitivity to light, confusion, painful stiff neck, seizures, and inappropriate drowsiness. Inappropriate drowsiness is when the drowsiness doesn't quite fit the context. Someone who's drowsy when awoken for pre-rounds at 5 a.m., for example, should not be considered drowsy in a neurological sense, whereas someone who's having difficulty staying alert in the middle of a conversation in the middle of the afternoon would be. Symptoms related to infection include fever, rash, tachycardia, hypotension, and tachypnea. Including the manifestations from the previous slide, there are some indications from pediatric and nonverbal patients that are important to review. A young child or nonverbal person may not be able to tell you that they have a headache, that their neck hurts, or that they simply don't feel well. Important manifestations include sharp irritation with positional changes, which may indicate neck pain, frantic eye movement, which may indicate pain in general, bulging fontanelles indicating an increase in intracranial pressure, wincing in light, lack of appetite, or difficulty feeding. If these findings are present, the diagnostic process for bacterial meningitis is relatively standardized. Typically, nasal and throat swabs will be taken to try to identify if the bacteria is present at all. Blood cultures are also drawn to determine if the bacteria has reached the blood. The definitive diagnosis for bacterial meningitis is a cerebrospinal fluid sample drawn from a lumbar puncture, as you see above. That sample will be cultured for bacteria. A positive test would reveal decreased glucose, because the bacteria has been eating that, increased white blood cell count from the infectious process, and an increase in protein. Bacterial meningitis requires infiltration of the blood-brain barrier, an infection of the central nervous system. So we need to have a cerebrospinal fluid sample to provide a definitive diagnosis. An MRI and a CT of the head will also be done to evaluate swelling in the brain. Treatment for bacterial meningitis is intravenous antibiotic therapy, typically vancomycin and ceftriaxone. Of course, allergies must be assessed and changes to the treatment plan should be made as needed. Additionally, corticosteroid therapy helps to decrease inflammation, such as dexamethasone. Along with treating the infection and inflammation, supportive therapies such as IV fluids and nutrition therapy will be included as well. The increased pressure inside of the central nervous system can and often does result in permanent neuronal damage with long-term effects. 75% of patients experience intracranial complications, including seizures, most commonly hearing loss, ischemic or hemorrhagic brain damage. Over 30% have systemic complications, most commonly mobility changes. And over 40% of children who have bacterial meningitis experience developmental delays, impacting them for the rest of their lives. The impact of bacterial meningitis can be life-changing, and an interdisciplinary approach, including nursing care, pharmaceuticals, occupational therapy, physical therapy, and neurology care, is key to success. In summary, bacterial meningitis continues to be a dangerous threat to people all over the world. The disease moves fast, and it's our responsibility to stay vigilant for warning signs, keep patients out of the hospital, and get them back to their lives. This is my works cited page and the conclusion of my presentation. Thank you for your attention.